Hello, and welcome to the webinar on a rare liver disease known as Wilson disease. We are happy to have you with us for this informative webinar. I am Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us. Liver Health Foundation is a patient advocacy, a 501c3 nonprofit serving in Great LA, Inland Empire, Orange County, and portions of Arizona and Northern California. Our job is to represent millions of liver patients in California and beyond, with the mission to support liver patients, their caregivers, and family members. This year, Liver Health Foundation will host several webinars on rare liver diseases to raise awareness and provide information to all. There are over 300 million people worldwide who are living with a rare disease. Despite the name rare, between 3.5 to 5.9% of the population is affected by a form of rare disease. Tonight's webinar is about Wilson disease, a rare genetic liver disease that impacts the liver, eyes, nervous system, brain, and can damage other organs if left untreated. Wilson disease happens when there is an excessive buildup of copper in our bodies, and it affects an estimated 1 out of every 30,000 people. Among people diagnosed with Wilson disease, 35 to 45% already have cirrhosis at the time of diagnosis. Cirrhosis can unfortunately end with liver cancer and require liver transplant. So it's very important to understand what Wilson disease is and how to live with it without further damage to our lives and our livers. Tonight, we will learn more about this disease and its impact on the patients. During the roundtable section of the webinar, our wonderful experts will respond to your questions about this disease. You're welcome to enter your questions through Q&A or chat options. Now about my disclaimer. Please remember, information given by our experts is not a substitute for advice given by your own physician or healthcare providers. This program has been made possible by an educational grant from Orphalon Pharmaceuticals. We thank Orphalon for their support. I'm happy to introduce the president of Orphalon Pharmaceuticals in the US, the webinar's exclusive sponsor. Dimitri came to the rare disease world via his graduate school connection with Orphalon CEO, Dr. Naseem Amin. They both attended the Kellogg Business School in Chicago in 1990s. Naseem asked Dimitri to lead the US launch at the start of 2023, which ultimately resulted in hiring 27 people across the US. Prior to that, Dimitri had a long career in healthcare. Most recently, he was a regional manager in Europe for Abbott, responsible for 12 countries. Orphalon is originally a French company and now operates across the EU and US, employing just north of 100 people. The company, Orphalon, is laser focused on its single product to treat Wilson disease. Dimitri will tell us more about Orphalon and their work in finding treatment for Wilson disease. Mr. Paramanov, we are ready for your presentation.
Thank you. Thank you very much, Farah. Great to be here and wonderful to be involved with all of you. And I know some of you already and some of you are already our customers. So we are a small company, just north of 100 people worldwide. And we developed a new drug for Wilson disease. And Wilson disease is all we do. We sleep, drink, and dream about Wilson disease 24/7. So if out there, some of our folks today are Wilson disease patients, I just want you to know that we are squarely in your camp, and we're doing everything to lessen the burden of the disease for you. We're doing a lot of research. We are doing new formulations of this drug. We are doing a new diagnostic test that we are putting through clinical trials, and we'll keep working for you until we get further FDA approvals. Our drug was FDA approved in 2022. It was commercially launched in the US in April 23, so just more than a year ago. We are very excited to be working with the hepatology doctors across the USA who treat you. We are very pleased so far with the results. We have north of 100 patients already been prescribed this drug in the US. And even though, of course, we all know that it's a fairly rare disease, from epidemiology modeling, the number is always quoted as around 1 in 30,000 population have the disease. And so that's the number we try to manage to, whereas in effect, when we look at the broader population, what's visible to us is about 5,000 patients that are actively managed for Wilson disease across the United States. And Dr. Jeffrey Cohn is one of these people who manages them. So Dr. Cohn, I leave it off to you and your expert presentation.
Thank you so much, Mr. Paramanab. We are very, very appreciative of Orphalan's support. It is my pleasure to introduce a great friend of the Liver Health Foundation, Dr. Jeffrey Cohn, who has generously accepted to be the presenter for tonight's program. Dr. Jeffrey Cohn is Professor of Clinical Medicine, Medical Director of Liver Transplant Program, Keck School of Medicine of USC. Dr. Cohn received his fellowship training in gastroenterology and transplant hepatology from the Keck School of Medicine and Cedars-Sinai Center in Los Angeles. He is board certified in internal medicine, gastroenterology, and transplant hepatology. Dr. Cohn's primary research interests are in liver transplantation, hepatocellular carcinoma, and viral hepatitis. He has written and co-authored several abstract and peer-reviewed articles on various topics, such as chronic hepatitis C and liver transplantation. He is also a distinguished and sought-after lecturer. Dr. Cohn is a member of the Liver Health Foundation's Medical Advisory Council. In 2023, Dr. Jeffrey Cohn, Dr. Yuri Genig, and Liver Transplant Program at Transplant Institute, USC, received Liver Health Foundation's Award for Excellence in Healthcare. We could have not been prouder to present the award and thank Dr. Cohn for his so many years of saving liver patients' lives. Dr. Cohn, we are honored to have you with us. Thank you for your support and participation, and we are ready for your presentation.
Yeah, thank you very much, Farah. I really appreciate it. So I think Wilson disease, I think, is one of the most interesting diseases, and I think this is a really interesting time because I think the sort of ways of diagnosing and treating this disease are really changing. And it's really important to diagnose it because if you diagnose it early, it's completely treatable. It's not curable at this point, probably with gene therapy at some point, but it's treatable and it's containable. And this just pays homage to Dr. Wilson, who didn't discover the disease, but sort of described it and sort of characterized it, and sort of the modern sort of Wilson disease is named after him. And I appreciate everybody saying Wilson versus Wilson's disease, because it really correctly is Wilson disease. So I put this slide up, and I'm hoping some people put in the chat. Maybe they know what this is and why would I put this picture here. And I've done several grand rounds and different talks on Wilson in the past, and I always have this picture. And so far, nobody's actually gotten the answer, but I'm hoping somebody on this panel or in the audience might. So what is Wilson disease? It's a very rare disease. About 1 in 30,000 people have it. It causes copper accumulation in the liver and throughout the body. And it's passed from parents to children, so it is inherited, and we need to be cognizant of that because if we have patients with Wilson disease, we need to make sure that we apply proper screening for appropriate family members. Copper builds up in the liver and eventually other organs and can cause really a lot of problems. And again, it's the manifestations are really preventable if caught early. It's often diagnosed in younger people, but I actually have a patient who I diagnosed in her 50s a few years ago. And after that, I think her sister was diagnosed in her 50s. So we shouldn't exclude people that are not in their sort of second, third, fourth decade of life, meaning 10 to 20, 20 to 30, 30 to 40. It can occur later as well. So this just shows us that, food contains copper. And when copper is in the body, we need to be able to get rid of it. And most of it is excreted in the bile, a little bit in the urine. And if patients have or people have a genetic defect, they can't actually excrete it. So if they can't excrete it, it gets caught up in the liver and then sent around the body and causes all sorts of problems in various tissues, which we'll talk about. So what are the clinical presentations? I should first say, commonly, nothing. Second of all, neuropsychiatric, such as oftentimes teenagers, adolescents, people in their 20s, 30s, difficulty concentrating, sometimes depression, sometimes difficulty in school. I always ask, patients about whether they had, difficulty learning or difficulty in the classroom environment. A lot of patients come in with mildly abnormal liver tests, and they're diagnosed with, quote, fatty liver or autoimmune hepatitis, which could be a common presentation for these patients. And I would say most of the patients I see were actually diagnosed with fatty liver. And yes, they have, quote, fatty liver, but the fatty liver is due to Wilson disease. Patients can actually come in with signs and symptoms of cirrhosis. Like any other patient with cirrhosis, they can have all of the manifestations of what we call portal hypertension, with bleeding from varices, ascites, jaundice, things like that. The most worrisome and troublesome presentation is acute liver failure, where somebody comes in very, very, very sick. And if somebody comes in very, very acutely sick, often with kidney failure, acute jaundice, their blood cells, red blood cells get destroyed. Those are people that tend to need liver transplants in order to cure them. This just shows the sort of various clinical patterns of Wilson disease. And our major liver society, the American Association for the Study of Liver Disease, actually put out treatment guidelines, and really guidelines just about how to approach Wilson in general. And I'm going to show the two major features here that I just mentioned, the neurologic and the other symptoms, because I want to show you some pictures of what these might look like. But all these presentations are things that can occur in people with Wilson disease. And again, many people have no symptoms, but these are the various things that you can see. Many of you may have heard of Kaiser-Fleischer rings. It's actually a C between the S and the H here. And it's actually deposition of copper around the cornea. And as you can see here, it's pretty obvious in this person with blue eyes, but in somebody with more sort of brown or hazel eyes, you might not notice it as much. And I think I saw that there were some questions that came from the potential audience that came out a couple of days ago. And usually we send patients to ophthalmologists when we're concerned about it, because a slit lamp exam is the best way to look for these Kaiser-Fleischer rings. Another manifestation, which is less common, is called a sunflower cataract. And this is actually the lens with what kind of looks like a sunflower. And that's characteristic, but not very common. So the Kaiser-Fleischer rings are most common in terms of the eye manifestations. Another manifestation that one might see is actually deposition of copper in this part of the brain. And this is a part of the brain that controls movement. And as we'll talk about, a lot of our patients with Wilson disease actually have movement disorders, difficulty speaking, tremors, and those symptoms emanate from this part of the brain where copper can deposit. And this was in a very, very early description of Wilson disease back in the 19th century, when they actually noticed that there was a deposition of copper in brains in people with movement disorders. These are various manifestations that can occur throughout the body. It can affect the kidney, it can affect the heart. We talked about the eyes, we talked about the central nervous system. There could be basically arthritis and rickets in the bones, and sort of features of acute liver failure, acute hepatitis, portal hypertension, cirrhosis, jaundice, and in many cases, virtually nothing. So in terms of normal dietary copper, I know this a little bit small. But usually when we've taken copper, most of it some of it gets absorbed, some of it ends up in the stool, and most stream gets processed within the liver, gets excreted into the bile, and then the bile it gets excreted into the stool. And that's where most of the copper is lost. Some of it is lost also in the urine. In people with Wilson disease, they can't actually get the copper from the liver into the bile, and so it builds up because not that much can actually get out of the in the urine unless patients are on treatment for Wilson with what we call chelating agents, which we're going to talk about. The major genetic defect is in what we call chromosome number 13. And I know this is a very complicated slide here. And it's really meant to show that that patients with Wilson disease have a problem in getting aceruloplasmin, which is a protein that binds copper. We can't actually get the copper onto the ceruloplasmin, and the reason that we can't get it on there is because we have a defect copper on the ceruloplasmin. It also means that we actually can't get the copper out of the liver. And while ceruloplasmin is not actually the cause of the problem, it's a marker for the problem. So this gene actually codes for a protein called ATP7B that allows copper to get onto the ceruloplasmin protein and also allows it to get out of the liver into the bile and out of the body through the intestines in the stool. So in terms of diagnosis, again, this is from the guidance that I talked about earlier that were recently published. These were the first guidelines from our society in many years. And I'm just going to read this because I think it's really, really important. So Wilson disease should be considered in any individual with liver abnormalities of uncertain cause. Age should not be the basis for eliminating a diagnosis. When I was training, I was told people over the age of 40 were not diagnosed with Wilson, and that clearly isn't the case. And I think there was a question in the chat about somebody who was, I think, over the age of 50 that ended up with pretty severe Wilson disease. And so, you know, if we don't have an explanation for the liver disease, we should think about Wilson disease. It should be excluded in any patient with unexplained liver disease associated with a neuro or psychiatric disorder, especially in younger people. So, and really in teenagers and people in their 20s, any kind of new psychiatric diagnosis, mood problems, etc., are often, those patients are screened for Wilson disease even by psychiatrists. And a psychiatric evaluation is essential for any patient with Wilson because they can actually develop neuropsychiatric problems that can be exacerbated over time. So we want to diagnose that. Anybody with acute liver failure, or it's really not clear, should be ruled out for Wilson disease. And the reason that's really important is because some causes of acute liver failure actually can respond to other kinds of therapies. For people with Wilson disease with acute liver failure, really liver transplantation is their only option for survival. Something if patients come in and it's really unclear, you know, why they have hemolysis, especially if it's determined that it's not due to an immune system problem, they should be considered for Wilson disease. And really, any clinical presentation that doesn't make a lot of sense, especially in the in the brain, the neuropsychiatric issues, musculoskeletal cardiac issues, disease, and perhaps with multi-system involvement. So things have really evolved over time. And so it's not really the hepatologists necessarily that are even diagnosing or considering Wilson disease. It might be the hematologist, it might be the neurologist, it might be the psychiatrist, it might be the cardiologist, it might be sort of work together on the patients. So things to watch out for, as I mentioned, again, deterioration in school performance, depression, personality or mood change. That's about a third of the presentation, especially in younger people. A mild tremor, especially new onset tremor. Somebody starts developing cramping or stiffening of muscles. Again, that's due to the central nervous system effects of Wilson. Ataxia, which is loss of coordination of movement. People being off balance. This could be younger people, this could be older people. And then dysarthria, which is speech disturbance. Suddenly or over time, you notice that, oh, your loved one or friend you're having trouble sort of understanding them. Those are all things that can be seen in Wilson. I'll also mention that a lot of these things can be seen in Parkinson's, and sometimes patients with Wilson actually have Parkinsonian types of symptoms. And that's because the area where the copper seems to be deposited in the brain is the same area that's affected by Parkinson's disease, treated very differently. So you want to make sure you diagnose somebody with Wilson disease if that's what they have, because again, the treatment is very different. So how do we test for it? Well, we want to do a liver panel. Many patients have abnormal liver tests, some don't. A complete blood count, serum copper, the free serum copper. I put this up here because this is actually a depiction of somebody who actually has something called apoceruloplasmin, which is the sort of protein for ceruloplasmin. If the copper doesn't bind to it, then the copper in the blood is high. It turns out the copper in the blood that's high is actually what we call the free copper, not the copper that's bound to the ceruloplasmin. This is the copper that's toxic to other organs. The copper that's bound to ceruloplasmin just sort of goes around in the bloodstream, deposits ceruloplasmin copper where it needs to go, and the rest of it doesn't really cause any harm. It's this free copper. The problem is that if you measure a total serum copper on people with Wilson disease, it tends to be low because the serum copper actually measures the free copper plus the copper that's bound to ceruloplasmin. So that combination is low, even though the free copper is very high. As was mentioned by the Orphalon people, is the testing for copper in the blood is actually very, very poor at this point in terms of reliability. So if you do a free copper test or a total serum copper test in one lab, it's very different than another lab. In one patient, the free serum copper could be very low, even though they have Wilson with actually very high serum copper, free serum copper, because the tests aren't very good. Ceruloplasmin is very important. Again, it's not a marker of the pathophysiology of Wilson disease, but it's a marker of having Wilson disease, because if you can't incorporate copper into ceruloplasmin, you're not going to measure much ceruloplasmin, because the ceruloplasmin is actually very unstable, and when it gets produced, it gets destroyed right away. And so you can't measure it. So not measuring ceruloplasmin is a way of actually helping us diagnose somebody with Wilson disease. There are some genetic abnormalities where people don't make ceruloplasmin. They don't have Wilson disease. They just don't make ceruloplasmin. It's a very different process. And an iron panel, for interesting reasons, people with Wilson disease actually don't handle iron very well, and a lot of the patients are diagnosed with what's thought to be hemochromatosis, which is an iron overload disease. And actually they have Wilson disease. And actually you see, as you treat patients for Wilson, their iron panels actually can improve. Really the hallmark of testing for Wilson disease in terms of the laboratory testing is the ceruloplasmin plus the 24-hour urine copper and creatinine. Creatinine is made by cells in the body. And when it gets excreted into the urine, which is the normal pathway for it, it gives us an assessment of whether or not number one, the kidneys are working very well, but also we want to see a certain amount of creatinine in the urine to tell us that the collection is good. So if we send somebody to a lab, they pick up a bucket, they measure their urine, or they collect their urine, which isn't the most pleasant thing in the world, and then they measure the 24-hour urine copper. If the creatinine level in the urine is, say, very low, then it tells us that this 24-hour copper result may not be very accurate, because it might not be an adequate collection. They may have missed some. Usually we want to see at least a gram of creatinine per day. So for instance, if it's a half a gram of creatinine, the 24-hour urine copper isn't very reliable. If it's 1.5 grams of creatinine, it probably is reliable. And this is a very important test, because it tells us about, number one, it helps inform whether somebody actually has Wilson disease. It also helps us monitor patients while they're on treatment. I'm not going to go through this whole algorithm, but there are two major algorithms. One is for people that present with Kaiser-Fleischer rings, and one for people who present without Kaiser-Fleischer rings. And based upon the ceruloplasmin level, the amount of 24-hour urine copper, etc., we can determine whether or not somebody has definite Wilson or perhaps not Wilson. And that's where we might go on to other testing, such as genetic testing, which we have a test for that genetic defect that I talked about, or perhaps a liver biopsy to see whether there's actually a lot of copper on the liver biopsy. But liver biopsy is not needed for diagnosis of Wilson disease. Again, I think we sort of talked about these things already. I'm not going to go through this one again. Talked about this already. So again, the apoceruloplasmin, if it doesn't bind the copper, you end up with a lot of problems. And this is just depicting how having that ceruloplasmin is very important for iron transport. And if you don't have ceruloplasmin, your iron is overloaded, and you can actually end up with iron deposition in various tissues. The genetics are really important. So here the mother, this actually comes from a publication in the UK, which is why it's mum. So if the mother is a carrier and if the mother's a carrier and the father's a carrier, there's a 25% chance that any given child will have Wilson, and there's a 50% chance that any given child will actually be a carrier. Now, it doesn't mean that if you have 3 children, your 4th child is going to have Wilson disease. Each child has this percentage. So a 25% chance of not being a carrier, a 25% chance, or a 50% chance of being a carrier, and a 25% chance of actually having Wilson disease. And this is really important for family planning later on. If the mother is a, well, let's do this one first. If the mother is not a carrier and the father has Wilson disease, none of the children will have Wilson disease, but they'll all be carriers 100% of the time based on what we call Mendelian genetics. If the mother or the father has Wilson disease and the other parent is a carrier, then 50% chance of actually having Wilson disease, and then a 50% chance of being a 50% chance of actually having Wilson disease, and a 25% chance of actually being a carrier. Sorry about that. I messed that up. I messed that one up. Sorry about that. Oops, I'm not able to advance right now. Okay, so evaluating relatives is really, really important for determining whether or not a relative has Wilson disease. So what I would say is this is sort of a guidance. What I tend to do is if I have a patient who has Wilson disease and they have siblings, I actually like to do the genetic testing for Wilson disease, because if it turns out that the genetic testing is negative, then that child will not have Wilson disease. And the reason that we can actually do that is we can actually check the person with Wilson disease for their genetic abnormalities, hone in on what their abnormalities are, and then test their siblings or other relatives for the actual same mutations. And again, it's really important to screen patients or screen patients' family members, because if they don't, if they're, if they have Wilson disease and they're untreated, they're going to have problems later on. And there are various algorithms in terms of doing blood tests, in terms of doing urinary tests, and in some cases we might want to do liver biopsies. There are a lot of questions that came up about treatment for Wilson disease, and the 2 major treatments that we start out with are D-penicillamine and trientine. These are what we call chelating agents. And it turns out that if we take an oral medication that gets absorbed, it can actually bind the copper, and the copper is actually bound to this material and then passed in the urine. And these are very, very effective. They've been used for many years. D-penicillamine, unfortunately, has a lot of side effects. I must say a lot of my patients have had fevers, have had rashes. They can actually develop a lupus-like reaction and all these other problems. And also poor wound healing. So if patients are going to go for surgery and they're on penicillamine, we tend to not want to use penicillamine. And also during pregnancy, especially because if, say, the mom needs a C-section or a episiotomy or something else, they might not heal very well. Trientine is very well tolerated. It causes very few side effects. Historically, the major problem with trientine has been it had to be refrigerated, but there are newer preparations where they don't have to be, it doesn't have to be refrigerated. If somebody's on D-penicillamine, they need to be on vitamin B6 because D-penicillamine actually depletes vitamin D6. The next major therapy is zinc therapy, which works differently. So when we take zinc in our diet, and in fact, or take supplements, if we take too much zinc, the zinc ends up causing loss of copper from the cells within the intestines. And what ends up happening is zinc gets absorbed in the intestines. It induces an enzyme in the intestinal cells that actually likes to bind copper. When it binds the copper doesn't get absorbed, and it actually gets released in the intestinal cells. And those lining cells have a high degree of turnover, so they kind of disappear at a high rate, and the copper is released into the stool, and you can actually measure copper in the stool. So people that actually have zinc overdoses actually end up very, very copper deficient. And that's sort of how they figured out that zinc could actually be a treatment. So we tend to start with D-penicillamine or trientine. I prefer trientine because of the side effect profile. And then we often add zinc later on and stop the other drugs when the sort of copper is unloaded, keep them on maintenance therapy. Another very important part of the treatment is actually the diet. And these represent the sort of low copper foods, medium, high, and very high copper foods. And just keep in mind, if people are eating a lot of high copper foods, they might have more trouble actually managing their copper levels and managing their medications. Things like shellfish are very, very difficult. Chocolate is very difficult. Mushrooms are very difficult, and nuts are very difficult. And I have several patients who are vegetarian. They eat a lot of nuts and mushrooms, and it becomes very difficult for them sometimes. So I always send all of my patients to a dietitian. The other thing is that if somebody has, copper pipes in their home, they could either check the level of copper in their water, or I usually just ask the patients to drink bottled water, which is what most people do anyway these days. So in terms of pretreatment Wilson disease, again, most of the copper that our bodies don't need get excreted into the stool through the mechanism of ATP7B, causing copper to be excreted into the bile and then into the stool. On chelation therapy, we actually bind it in the blood. It ends up in the urine, and that's the primary way that that chelation actually works. With zinc, it's mostly through the stool. So we actually, again, increase the copper loss in the stool by causing the copper not to be absorbed by the enterocytes, which are the cells that are lining the intestines. And eventually the urinary copper, hopefully the copper levels stay good, and we can actually follow the urinary copper to see whether or not the zinc is actually working properly. And I'll go over the testing strategies in a second. So in terms of how do we monitor people that are actually on treatment, again, similar to before, we do liver panel, we do a CBC, a complete blood count. We do serum copper, the free if we can. We monitor the ceruloplasmins, and we monitor the iron panel. The 24-hour urine copper and creatinine are followed to see whether or not the chelation therapy is actually working. I'm going to present a patient later, and I'll show you kind of what happened to her when she started on the chelation. The copper starts going up. For patients with cirrhosis, advanced fibrosis, we treat them not only as we would for Wilson disease, but we also treat them as we would for other people with advanced fibrosis and cirrhosis. We do liver cancer screening. We do screening for esophageal varices. And then we, treat their ascites, encephalopathy, and bleeding, which is the fluid buildup, the confusion, and varices and things like that. In terms of the clinical course, if patients are diagnosed early, which most of mine are, the treatment prevents progression and complications. But the patients need to be compliant with the medications. It's not always so easy to use several times a day, and people forget. Delayed diagnosis treatment may prevent further decompensation, such as cirrhosis or neurologic symptoms, because once they occur, they tend to be irreversible. So we want to treat people before they have neurologic symptoms. Acute liver failure, which is the patients that come in with renal failure, confusion, hemolysis, which is copper accumulation in red blood cells, where the red cells get destroyed and the blood counts go down. The most common reason is actually people that are on medications such as chelation or zinc, and then they stop their meds or they're not compliant with all of their meds. And that seems to sort of really provoke acute liver failure. And in many of those cases, or most of those cases, they need a liver transplant. For some reason, females were more prone to acute liver failure than males are. There was a question, I think, about liver transplantation, and liver transplantation cures Wilson disease. If somebody has bad neurologic symptoms, they tend not to improve because the damage is sort of already done. But they tend not to get worse, although some of the medications we use for transplant can actually make symptoms worse. So we have to be a little bit careful with that. Since it's a genetic disease involving the liver, it does not recur. So this is, I just want to present really quickly a patient of mine, 18-year-old female. She had no symptoms, abnormal ALT and AST, and she had steatosis noted on her ultrasound. This is the ultrasound showing mild fatty liver. The spleen may have been a little bit big. I should also mention this is a thin young woman. I think her BMI was around 20. Not the classic patient that we see with steatotic liver disease. She had a FibroScan, which is a test for scarring, showing some scarring and a little bit more steatosis in the liver than the ultrasound mentioned. These were her labs, so her bilirubin maybe a little bit high, and the other liver tests were modestly elevated. Her iron stores were elevated as well. Worked her up, her ceruloplasmin was less than 3. I'm showing this. This is her total serum copper, which was low, which is the hallmark of Wilson, because again, the serum copper measures the total, which is the ceruloplasmin bound copper plus free serum copper. And because there's not a lot of ceruloplasmin bound copper, it tends to come out low, even though the level is actually high. So people with Wilson tend not to have a high total serum copper. It's usually a low total serum copper. We did a 24-hour urine copper on her, and just the collection based on the volume, she had 253.5 micrograms for 24 hours, which is quite high. I checked the Wilson disease gene, and she came back with 2 copies of one variant, which is, again, very, very suspicious. And I put her on chelation therapy, and you can see that her urinary copper increased by about 4-fold on the treatment, which is kind of what we see. I know there were some questions about sort of what the goals of therapy in terms of the urinary copper and how often to check, and it really depends on, your own doctors, and I don't really want to sort of get involved with those questions, but we like to check labs on a fairly frequent basis, especially the urinary coppers, the CBC, and the liver test, just sort of see how we're doing. And it turns out that if somebody's very compliant and the urinary copper drops to very low levels, we're probably overdoing it. And if the levels stay high, we're probably underdoing it. And if somebody's on zinc, we want to see usually a urinary copper level of someplace less than 75 to 100. If it's more than that, again, because we're not chelating, so we're starting with a copper that's not being affected by a drug that's actually causing it to end up in the urine, we're actually looking at the copper buildup. And if it gets too high, then the zinc is either not doing the trick, or we may want to consider stopping that therapy and starting something else. So I get back to my question here. So this is I don't know if I don't have the chat up right now, but anyway, this is a Bedlington Terrier, which is a famous dog, and the reason it's famous is I think it's never won the Westminster Dog Show, but in addition, this is actually animal model, a natural animal model for a Wilson disease-like process with inherited copper toxicity. They don't get Kaiser-Fleischer rings. It's a different mutation, but they can end up having liver failure as well. So I know I went a little bit over, so I'm going to stop sharing, and hopefully everybody else
Yes,
can get involved.
thank you, Dr. Khan. In fact, Doug, one of our audience member, responded that he thought that the dog had Wilson disease. Answering your
I want to send that person a prize, because I've never had a resident or fellow during any talk on Wilson actually get that right. So I want to know who that was.
I will send you an email address.
I know I would. I'm going to make a donation to the Liver Health Foundation in his name.
In his name. Okay. Thank you so
Yes.
much. We appreciate that. I hope Doug appreciates that too.
Yeah.
Yeah, very informative. Thank you, Dr. Khan. Very important and powerful presentation. We don't hear much normally about the rare liver diseases, but as you all can see how important these are. Now we will start the second half of the webinar, the roundtable conversation with our guest experts and Dr. Khan. We respond to the question we had received, but please everyone bring us your Q&A or a chat function, and we try to get to all of them. It is now my pleasure to introduce Dr. Mohammed Elkebani. Dr. Elkebani is Associate Professor, Department of Internal Medicine and Surgery, member of the Liver Transplant Executive Committee, Division of Transplantation, Ronald Reagan UCLA Medical Center. Dr. Elkebani received his MD and BCH from Cairo University School of Medicine in Egypt. He completed his fellowship in hepatology at the University of Southern California School of Medicine, where he received his clinical hepatology diploma. Dr. Elkebani specializes in treating conditions such as hepatitis and fatty liver disease, as well as other liver-related issues. He's also experienced in treating inflammatory bowel disease, such as colitis and Crohn's disease, and swallowing problem known as, I hope I pronounce it correctly, dysphagia, hopefully. Dr. Elkebani is a member of the American Association for the Study of Liver Disease and has been a primary investigator in several clinical trials. He is also a reviewer for the Journal of Clinical Gastroenterology. Dr. Elkebani has been nominated several times for UCLA's Exceptional Physician Award. Dr. Elkebani, welcome. Thank you for your participation. We look forward to your conversation at the roundtable.
Thank you for the generous introduction.
Thank you so much. It's our pleasure to have you with us. It is now my pleasure to introduce Dr. Haider Jamal. Dr. Jamal is Medical Director, Hepatology, SJMC, Associate Medical Director, Subspecialty, at the Providence St. Joseph Heritage Medical Group. Dr. Jamal is a general gastroenterologist with additional training and expertise in hepatology. With his team of nurse practitioners and dietitians, Dr. Jamal leads the liver clinic, which focuses on patients with complicated liver diseases that require more intensive management. This clinic has access to state-of-the-art imaging, interventional radiologists, oncologists, and hepatobiliary surgeons in order to provide comprehensive attention to patients. The use of FibroScan enhanced the clinic's accuracy for assessing damage to the liver without having to do a liver biopsy. Another passion of Dr. Jamal is the development of clinical research trials in support of creating new opportunities for the patients with the specific GI diseases. Some of the clinic's recent trials have been for the treatment of patients with low platelets from cirrhosis of the liver. Dr. is also an expert in treatment of Barrett's esophagus, a precancerous condition which can lead to esophageal cancer. Dr. Jamal has a passion for teaching students, nurses, and physicians. He's focused on providing compassionate care as part of a team of excellent physicians, which is what keeps him glued to the St. Jude Heritage family. Dr. Jamal, thank you and welcome to the Wilson Disease webinar. We are happy to have you with us. Okay, now we are going to start.
Farah, can I just say one thing? I think I confuse people with the genetics, and I just want to just clarify something because I think I sort of
Please.
I wasn't very clear. If both parents are carriers, then 25% of the children will have, a child has a 25% chance of having Wilson, and if one parent has Wilson and the other is a carrier, 50% will have a chance of having Wilson, and there's a 25% or 50% chance of the other being carriers. And if one parent has Wilson and one doesn't have any of the genes, then all of the children will be carriers. So I think I kind of went over that kind of fast, and I think I may have confused people. So sorry about that.
Thank you so much for corrections. We had some questions that I would like to start with one of them. I thought Dr. Khan Askina got confused whether the questions you wanted me to ask were the ones you emailed to me, or are these the ones that you deleted?
No, those are the ones that I wasn't going to cover. So
okay, so
Yeah.
I'll ask those. So one of the question has been how, when, and how often the copper level is checked in our usual annual checkup. Should we ask our primary doctors to check our copper level as we go for our annual checkup? Anyone, please.
I can take that. We usually don't check copper as part of routine physical exam. We do it only if we suspect Wilson's disease. And once Wilson's disease is diagnosed and patient started treatment, we check urinary copper initially after 1 month, and after that every 3 months, and then 2 times per year.
Dr. Jamal?
Yeah, no, so I don't think for a asymptomatic normal patient, that's not part of the usual testing. As Dr. Khan mentioned in his presentation, that there's lots of different kinds of presentations of these patients. And it's not necessary that the patients are gonna initially see us. I've had a few patients that have come to me after getting a routine optometry examination where the optometrist picked up on the Kaiser Flasher rings. So neurologic symptoms for some patients are the initial presentation. For some, it's the optometry examination. And then, of course, we also get patients that are referred because they had abnormal liver test, and an astute primary care physician ran a ceruloplasmin that was abnormal. And then therefore we go down the pathway of diagnosis.
The eye exam actually was another of the questions, because people were asking, can just when we go for normal, usual eye exam, if I wear eyeglasses, so every year I go check, make sure my eyes are still okay, and the same, I need the same kind of glasses. Do those doctors, as a rule, notice? And you're saying that some of them do notice and send the patients to specialists.
Yeah, and if it's abnormal, then of course they would do a slit eye exam that's more reliable.
The next question is, it says, I'm a 50-something young at heart man who is still bicycling regularly. I have been on a health kick and have been adding mushrooms to almost everything I eat or drink. My husband does that too. I know I have an unmuted gene that can cause Wilson disease. Can my diet, which is heavy on nuts, mushroom, and shellfish, trigger Wilson disease? Dr. Khan, do you want to start the conversation?
yeah, I mean, there are lots of carriers out there, and it's very unusual for a carrier to have any kind of symptoms or signs of Wilson. So I would say mushrooms are healthy, and I would eat the mushrooms.
And Dr. Al-Kabani, would you eat the mushroom?
Usually the rule of dietary copper is very minimal. As regards, for example, to control the disease, it does not have a big role. And to precipitate the progression, also it's very minimal role. So I will eat mushrooms too, despite I don't like mushrooms.
But this is somebody presumably who's a carrier, is that correct?
Yes.
So not somebody with Wilson disease, but somebody who's a carrier.
Is that
Yeah,
unmuted
one
gene?
copy.
He's a carrier. He's a carrier.
Yeah.
I would suggest that
So I think the risk is
he add some dark chocolate to his regimen.
Ah, really? But I heard chocolate is not good for Wilson disease. I love chocolate.
But I will say for people that are known carriers, if they're gonna go and have kids, they need to think about it. Like I have a, like I have a patient with Wilson and, she has Wilson, she has a, a kid. And, her husband's been tested to see if he's a carrier for any of the genes, just to sort of know what to maybe expect for the kids. And if somebody's a known carrier, if they marry a carrier, right, then there is a chance that a child may have Wilson. So at least it's good to know those things. It's a good thing to know if you have a genetic defect like that. I don't know whether 23andMe and Ancestry.com DNA testing, if they're actually telling people that or not.
I don't know.
Probably not,
Um,
because there are like 500 mutations. But
Dr. Khan, you touched on something, and I want to just go back for clarification. Wilson disease can be activated in any age. So 5-year-old can have Wilson disease. 75, 80 years old can just develop the symptoms at that age.
well, so again, I have a patient in her 50s who was diagnosed with Wilson by a very astute gastroenterologist, and had no symptoms, but she, I think, was diagnosed with fatty liver. And then it turned out her sister had Wilson, and then it turned out they had a cousin or something who died of Wilson disease. And it can present at various ages. I mean, I don't know. I think that's about the oldest patient I've seen that was diagnosed with it, but it's certainly possible. All of these diseases have different sort of degrees of, kind of when they present with problems. Part of it may be dietary. I mean, if somebody has Wilson, but they're on very, very low copper foods, perhaps it'll take longer. I'll also say that, we measure ceruloplasmin in people with Wilson, and there are various levels of ceruloplasmin. And because the gene that causes Wilson incorporates copper into ceruloplasmin and helps with excretion, there may be sort of varying sort of degrees of how somebody's affected by it. My patient was really not affected by it, just mild elevation in the liver tests and fatty liver on an ultrasound. But then we have, teenagers coming with acute liver failure. So it's variable. We should test for it. I didn't used to test for it in people over like 40 or 50, and now I just test for it routinely, and I found a few.
Oh,
I agree with Dr. Khan. We were taught at USC that Wilson's does
We
not
trained at the same place.
does not
Yeah.
come after 40. But nowadays, the literature showed 70 and 80 years old patients with Wilson's disease.
wow.
Yeah.
So we are never safe from Wilson disease.
But remember, it's very rare disorder, very rare.
And I'll say in people that are, not very young, some of the people that present with Parkinsonian symptoms might actually have Wilson. So it is important to consider it in a neurologic sort of presentation at a not very young age, because it's very different treatments. And, anyway.
Yeah, that
Okay, I
brings up an important point in terms of our training. So, to change our own mindset, you're absolutely right. I don't think about ordering ceruloplasmin over the age of 40. And so sometimes I have to force myself to think about those things, and I don't think I'm perfect on that.
next question. We are running out
Actually,
of
Farah, before you go on, one important thing: people with Wilson can have a normal ceruloplasmin, especially when patients come in with acute liver injury, because you're releasing ceruloplasmin. It could be normal, and then it gets degraded quickly, but you're measuring a level that could be normal. The flip side is somebody can come in with very, very severe acute liver failure and have a low ceruloplasmin because the liver's not making it anymore. And some people end up getting misdiagnosed with Wilson because they're very, very sick. Their liver is basically, dying. They need a transplant. Somebody checks the ceruloplasmin, it's very low. So a normal level could mean they can still have Wilson, and a low level might mean they don't have Wilson. So it's much more complicated than just ceruloplasmin.
a patient was asking, he just got liver transplant because his Wilson disease had gone so far that he had to have transplant. So now he's worried that his new liver can get Wilson disease again? Is this something that is in his genetics that will attack the new liver, or what?
He's cured.
Is cured for life?
For life.
Very good. So a lady is asking, my husband died of acute. Did you want to say something, Dr. Khan?
I'm saying, you know, if the risk of Wilson, if the prevalence is about 1 in 30,000, then there's a, you know, 1 in 30,000 chance, I suppose, that somebody can get a liver with Wilson. But it's very unlikely. I mean, we don't screen donors for Wilson disease
And that's
because
why
it's so uncommon. And I've been doing transplant forever, and I've never seen that happen. So,
and that's why as well accepting living donor from a history of Wilson's disease or Wilson disease family is not accepted.
Okay, okay. Okay, so this lady is asking, my husband died of acute liver failure when he was in his mid his liver and kidneys stopped working due to undiagnosed, untreated Wilson disease. Unfortunately, he passed away waiting for liver transplant. Is it possible to be in end-stage liver disease condition but not knowing about it? Does it happen often?
I think it is common to have Wilson's disease patients presenting with end-stage liver disease. The Wilson's is very silent and slowly progressive, can end in cirrhosis and decompensation. And usually the decompensation is acute on top of chronic. So he most probably had abnormal liver enzymes for a long time. Then he developed acute on top of chronic liver failure.
It says, I am a postmenopausal and post-breast cancer, 75-year-old woman. I will be on cancer medication for about. Does Wilson disease treatment that I'm receiving interferes with my cancer treatment? Do we know anything about cancer treatment, mixing with other treatments? No? Okay. We jump over.
I don't know.
Yeah, and Dr. Khan had says it's too
that's
specific.
really a question, I think. Can you hear me?
Yes.
Yes.
Can you hear me?
Yes. Yes.
I would ask. I would ask the oncology pharmacist to make sure there are no interactions.
Okay, I'm going to do the last question before we jump into a couple of other things. It says, my wife and I are parents to a Down syndrome daughter. If that was not enough, she was recently diagnosed with Wilson disease. Both my wife and I are gene carriers for Wilson disease. We're very concerned about her future. Do you know how Down syndrome and Wilson disease can coexist in one person, and what are the side effects of treatments that she is receiving for Wilson disease, and what will that do to her intellectual abilities? Dr. Jamal, you want to step right in? Yes?
Yeah, I don't have a personal experience of Down syndrome with Wilson's disease patient. But obviously the neurologic symptoms that may be associated with Wilson's would hopefully improve somewhat, depending on what age the patient is and how progressed their neurologic issues are. But certainly that treatment might improve some of that outcome.
All right, I'm gonna, Dr. Al-Kibani, Dr. Khan, did you want to say something, or should I move on?
Well, just to mention the general rules for neurological Wilson's disease, the cognition is rarely involved. There may be movement disorders, speech disorders, and gait disorders, but the cognition is very uncommon in Wilson's disease. What's interesting in these patients is she had two genetic disorders, Down syndrome and Wilson.
Right.
Yeah.
All right, I'm going to leave it at that and say a couple more things. And I want to say this, and I think it's very important for everyone to know that our presenters are here as volunteer physicians. They care deeply about liver patients. They use their own personal and family time to be with us and share their expertise with all of you in support of our efforts in helping liver patients and raising awareness of liver disease. My heartfelt appreciation to our doctors for their kindness and compassion. This is a good time right now to just diverse a little bit to hear a bit more about Orphalon's work. Please allow me to introduce Corey from PharmD, who has worked in medical affairs with Orphalon since 2023.
Hi, everyone. I'm Lori Gravich. I help out Farrell with these webinars, so I'll just kind of take over and close this out. And if Corey is able to rejoin, then he can show us his presentation. So let me pull it.
I just got word that his computer crashed.
Oh, no. All right. Well, if he comes back, we can let him present. But thank you, Dr. Khan, for your excellent presentation. We're honored to have you with us tonight. And thank you for your participation and support, Dr. Kabani. It was a great conversation. And thank you, Dr. Jamal. We appreciate your support and collaboration with the Liver Health Foundation. And a big thank you to Orphalon Pharmaceuticals for sponsoring this webinar. These webinars are made possible by your support. And it looks like perfect timing as we're thanking Orphalon. Corey is back, so I will stop my slides and.
I mean, I can say a few words while Corey is booting up his system. So
Yes.
we've launched this drug in Europe. It's already been 5 years. So we have about 1,100 patients in Europe on this therapy. And now we have just north of 100 people in the US on this therapy. The drug is called Cuvrior. It was the first really new Wilson disease treatment approved in more than 30 years. And what we did is we studied this drug on in patients that were being treated with penicillamine, and that were fairly stable patients. So the idea was to show that our drug could perform as well as penicillamine, the biggest advantage of the drug really is the fact that it's a trientine, so it's a well-known category of a drug that Dr. Khan described that has traditionally well established that it has less side effects than the penicillamine. But trientines that came before us are all produced in capsules because they're actually an oil. So an oil needs to be in a capsule, and therefore it needs to be refrigerated. So all the trientines that have been on the market before, the patients have to live with an ice box or live close to their fridge. And so this was the big difference. We were able to make a trientine that can be made as a tablet and does not have to be refrigerated. So that's what's made a substantial difference in people's lives.
Yes. I think Corey is connected. Corey, you want to say a few things before we...
I'll just let you know when to switch the slides here. So as Dimitri mentioned, the drug name is Cuvrior. It's a new formulation of trientine. It's trientine tetrahydrochloride. Go to the next slide here. So this was approved here in the US by the FDA in April of 2022. It came to market just this last year. Cuvrior is indicated for the treatment of adult patients with stable Wilson disease who are decoppered intolerant to penicillamine. So this differs from some of the past formulations of trientine, which you may be familiar with, like trientine hydrochloride, in which the indication was patients were intolerant to penicillamine. Cuvrior works by two mechanisms in your body. It's a copper chelator, so it's going to bind copper in your body, and then it'll be excreted through the urine. The other way it works is that it's going to prevent copper absorption in your gastrointestinal tract. The last FDA-approved medication for Wilson disease was in 1997. That was zinc acetate. So it's been a while since a new medication has come to this space. And the other formulations of trientine, such as trientine hydrochloride, those came about in the late 1960s. Go to the next slide here. So as you can see here, Couvreur is supplied in a handy blister pack, so it makes it easy to take on the go. Each tablet is 300 milligrams and includes 150 milligrams of trientine base. The tablets are film coated. They're a little bit smaller, so they're easier to swallow. They're also scored, so for those that have issues with swallowing, they can cut them in half and take them that way. It also allows healthcare providers to be a little more flexible with the dosing. Now, the main advantage of Couvreur, which really differentiates it from some other trientine products, and Dr. Khan had mentioned this, is that no refrigeration is required with Couvreur. It's stable at room temperature. And Couvreur is backed by the safety of trientine products over the past 35 years. Next slide. So starting dosage for Couvreur, it can vary. So from 300 milligrams, which is one tablet, all the way up to 10 tablets, 3,000 milligrams. And Couvreur is taken twice daily, so that dose would be divided in half. Just like other trientine products, it's taken on an empty stomach to help with absorption, at least 1 hour before meals or 2 hours after meals, and then separated apart from other medications by at least 1 hour. Like I mentioned, the main advantage is that it's stored at room temperature and excursions between 59 and 86 degrees Fahrenheit are permitted. If a healthcare provider chooses to put a patient on Couvreur when converting from trientine, other products, penicillamine or zinc, the dose of Couvreur is not substitutable on a milligram per milligram basis. So in those scenarios, they would choose the most appropriate starting dose for the patient. Next slide. Important safety information. So Couvreur is contraindicated in those with hypersensitivity reaction to trientine or any of the excipients in Couvreur. There is a potential for worsening of clinical symptoms at initiation of therapy, including neurological deterioration, which can occur at the beginning of therapy due to mobilization of excess stores of copper. If this occurs, adjust the dosage or discontinue therapy if condition worsens. Copper and iron deficiency can also happen with treatment with Couvreur. If iron deficiency develops, a short course of iron supplementation may be given. And then hypersensitivity reactions characterized by rash have been reported with the use of trientine. In our phase 3 study, 3 of the 26 patients treated with Couvreur developed a rash. 1 patient had to stop the drug due to the rash. If rash or hypersensitivity reaction occurs, consider discontinuing Couvreur. Next slide. Most common adverse reactions with Couvreur, and there's not many, it's very limited to gastrointestinal, so abdominal pain or change of bowel habits. Other adverse reactions include rash, alopecia, and mood swings. Drug interactions, like I mentioned, separate other medications at least 1 hour apart from Couvreur. And then Couvreur, being that it's a chelator, it can bind iron, zinc, calcium, and magnesium. If concomitant use is unavoidable, separate Couvreur at least 2 hours before and 2 hours after iron. And with zinc, calcium, and magnesium, separate administration at least 1 hour before and 2 hours after. Next slide. This is the last slide here. So this is our Navigator program, our patient assistance program that Orphalon provides. It's a no-cost program provided to patients on Couvreur. It includes access to a dedicated care coordinator. This is someone that's going to help you with staying compliant with the medication, help with refills, and any other questions you might have in that regard. We also have a copay program for patients that qualify and are commercially insured, as well as a quick start program. So if the treating healthcare provider chooses, we can get a patient started right away on drug while any insurance issues or PAs are being sorted out. And then lastly, we also offer a patient assistance program in those scenarios where there might not be insurance coverage for the drug if the patient qualifies. So thank you for letting me discuss this new treatment option for Wilson disease, Couvreur, which is a non-refrigerated version of trientine. If you'd like to learn more about it, you can always go to our website, www.couvreur.com. Thanks, Farah, and I'll turn it back to you.
Thank you so much, Corey. I appreciate it. I hope that the Wilson disease patients received enough information. For more information, please visit wilsondisease.org. That's Wilson Disease Association. I want to thank Dr. Khan for, Dr. Khan, thank you so much for your excellent presentation. We are honored to have you with us tonight. And
Of course, thank you.
thank you. Thank you for your participation and support, Dr. El-Kabbani. Great conversation with us. And thank you, Dr. Jamal. We appreciate your support and collaboration with us. Thank you again to Orphalon Pharmaceuticals. Okay, now for more, where we talked about for more information, now please join us on September 21st for Walk for Your Liver, Los Angeles. It's in Santa Monica. During the walk, we will feature many liver patients as they share their journeys with everyone. There will be refreshments for all, and children are welcome. We have face painting, balloons, music, dancing, everything you can imagine. Please visit our website, www.liverhealthfoundations.org, to register. Liver Health Foundation will host another webinar in July, on July 18th from 5:30 to 6:30 p.m. That the webinar in July is going to be on cirrhosis of the liver. As we talked here about our disease of Wilson disease, it was mentioned how important Wilson disease is that can cause cirrhosis of the liver. And I would like to have the slide number 18. Yeah, this is the cirrhosis. If you can, please put slide number 18. I want to say this is a special time for our own Lori Gravich. Lori has been working with Liver Health Foundation since 2020. Our sincere thank you to Lori for her continued support of our work, and congratulations to Lori and her husband for soon to be arriving their little boy. Lori will be off on maternity leave for a few months, enjoying her precious little one. We can't wait until you come back, Lori, but enjoy your baby.
Thank you so much, Vera.
Oh, you're very welcome. You have been wonderful, wonderful help. Liver Health Foundation is on all social media sites. We announce our events on our social media and website. Please visit us. Thank you to all of our doctors, Dr. Khan, Dr. El-Kabbani, Dr. Jamal, and thank you for our sponsor. Thank you for joining us this evening for this important webinar. We hope to see you at our upcoming webinar on cirrhosis on July 18th, and during the Walk for Your Liver Los Angeles on September 21st. Have a happy and safe 4th of July. Be well, take care. Thank you, and good night.
Thank you. Good night.
Good night.